From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello and welcome to our listeners around the world. You're listening to JAMA Dermatology Author Interviews. Thanks for joining us. I'm Dr. Adamson, the web editor for JAMA Dermatology and the host of this podcast episode. Atopic dermatitis is among the most common skin disorders affecting children in the United States. Children that develop atopic dermatitis early in their life carry a risk of developing allergic comorbidities, sleep disturbances due to itching, behavioral challenges, bullying, and even mental health disorders. As such, there's a growing interest in identifying strategies to prevent the onset of this disorder. Several studies have explored whether regular application of emollients in infancy could reduce the risk of developing atopic dermatitis, but findings have been mixed. A 2022 Cochrane review pooled data from multiple randomized controlled trials and found no clear evidence of benefit. A new study published in JAMA Dermatology, the Community-Based Assessment of Skincare, Eczema, and Allergies, or CASCADE trial, offers some new insights. In this episode, we'll take a closer look at the findings and discuss what they might mean for early skincare practices and eczema prevention. Dr. Eric Simpson is a board-certified dermatologist and professor and director of the Clear Eczema Center in the Department of Dermatology at the Oregon Health and Science University in Portland, Oregon. He's here to discuss this randomized, pragmatic, decentralized trial and what it means for patients, parents, caregivers, and clinicians. Welcome to the podcast, Dr. Simpson.
Thank you, Dr. Adamson. Thank you for your interest in the study.
I think it is quite interesting, and this area of research has been pretty active over the past many years, looking at ways of preventing this really common inflammatory disorder in children. Now, before we dive into the study, for those in the audience that may not know who you are, what kind of work you do, tell us a little bit more about what you do.
Yeah, thanks so much. So I'm a general medical dermatologist, and I have a special interest in atopic dermatitis, and I see both kids and adults, often with more moderate to severe disease. And you really nicely laid out actually in your introduction the burden of the disease that happens in kids and adults. And so I've been passionate about trying to bring relief to these patients over the course of the last 20 years of my career. So it has been quite the joy and satisfaction to bring people's life back with proper therapy. But one step above that would be, can we just prevent that altogether? And that's been actually, so far, my whole career has been trying to look at ways to prevent the disease so we don't have to move to topicals and systemic therapy. And it's been quite the journey. And there's been years and years of kind of allergy avoidance before I started. And so allergists primarily have been trying to prevent this disease for good reason, with also mixed results. And so I came in as a dermatologist wanting to see if we could focus on the skin and see if we can prevent the disease.
Yeah, you raise a really good point that when we think about inflammatory disorders, there's a lot of focus on treatment, which is, rightly deserved. But as you said, if we could find a way to prevent it, that would be truly something that would be impactful from a public health perspective, particularly if it's a, low cost, safe intervention, like putting on a moisturizer. And so, as I alluded to in the intro, there have been plenty other randomized controlled trials looking at emollients and whether they help prevent this disorder in children. Why this study? What is different about this study versus some of the others? Why did you embark on the Cascade trial when there were already other trials that existed in this space?
Yeah, no, that's a great question. And part of it is just purely logistics. So this was an NIH-sponsored study. And so the time of preparation, the time of kind of grant funding, and, we started this over 7 years ago, probably. And so this was before, let's say, that Cochrane review that showed, emollient use in high-risk populations doesn't appear to protect from developing the disease. There's been other systematic reviews looking at more narrow randomized controlled trials of prevention that has shown a 25% reduction from emollients. So even the systematic reviews are mixed, not just the trials. And the gap that this was filling back at the time of design, we were really looking not at a high-risk population. I get questions from parents all the time. What can I do to prevent the disease because I have had the disease and they don't want the same experience with their child or, things like that. And so the gap that was present was we didn't know in a normal risk population, so a population not at high risk, is that protective or not? And the way medicine works in the US, it's kind of hard to, and you don't have the time as a primary care physician to say, oh, this person's high risk, you should do this. This person's not a high risk. Let me do an extensive family history. And so it was really kind of a pragmatic approach. We also use pragmatic methodology, but it's kind of the bigger question was, if we just recommend or supply emollients to a population in general, can you reduce the burden in that population of atopic dermatitis in infancy? So it's really like a global question that took a special type of design to get to the answer to that question. And it was like, can all comers, if you just recommend moisturizer from birth to an entire population, can you reduce the burden of atopic dermatitis at 2 years of age?
Yeah. And it's usually these kind of questions, they go the opposite way. You try to see if there is a difference in a high-risk population, and then you bring it to a low-risk population and see if, yet again, it has an effect. And in this way, you're going the other way. And I do think that it was very nice that you did it in a average risk population. And in fact, the intervention was done in a primary care setting, not in dermatologist's office. Could you tell the listeners a little bit more about that? How you selected sites, generally who was eligible to the trial, and at what age did they come in? Was it like literally right at birth, or was it, a few weeks after? So can you give us a little bit more about the study design?
Yeah, thank you. I think dermatologists forget that the majority of atopic dermatitis is encountered in the primary care setting, right? We think we're the ones that treat atopic dermatitis, but that's not true. It's really primary care that treats and sees and diagnoses atopic dermatitis. And so as we're doing the sample size calculation as a team, I was recognizing that this was going to take 1,000 babies for us to answer the question. And trying to enroll 1,000 babies in academic centers was not going to be feasible. And that's what I'm most excited about, actually. One of the most exciting things about this study is my collaboration with primary care. In primary care, they have practice-based research networks. So these are pediatricians, family medicine doctors who run clinics in rural settings, suburban settings, and they have self-selected to say, I am interested in participating in research as a primary care clinic. And so I was fortunate enough to partner with the Oregon Rural Practice Research Network at OHSU. And they actually had a meta-network where they partnered with multiple rural clinics across 4 different states. And they already had relationships. They already had studies, mostly qualitative studies or quality improvement studies in primary care. But we already had relationships with these directors at academic centers that then have relationships with clinics in their states. And so they said, you know what? We enroll 1,000 patients at the drop of a hat. That's something we do every single day. And so that started that partnership. And I started learning about practice-based research in general and started seeing the benefit of when you do the research in clinics, that is directly applicable to patient care. It's closer to patient care than me doing what we call an explanatory trial, a very tightly controlled trial only in the academic center where we force patients to come in and we measure adherence. This is like completely opposite of that. And so this allows research to be done in the clinical setting and is pragmatically designed, and I can go over that in a second. But what the results of that type of research gives you is directly actionable.
And it's more generalizable.
More generalizable, absolutely.
Yeah. And so what do you mean by pragmatic design?
It's not done that much in dermatology. It's done a lot in the UK. It really makes a scientist who's used to tightly controlled experiments uncomfortable because you have to put all that tightly controlled methodology aside. And it's a spectrum between a very tightly controlled explanatory trial and a pragmatic trial. So there's no one or the other, there's a spectrum. And some of the main differences, I can't go into everything, but some of the main differences would be having a choice of intervention. So you don't choose the intervention, the patients choose, or the participants choose the intervention. That's one.
In this case, they had an option of 5 different emollients that they could use.
Absolutely. So our research question wasn't, does this one emollient prevent eczema?
Mm-hmm.
The research question is, if we provide or recommend bland emollients that we know improve the skin barrier, can we reduce the burden of eczema? That's the research question.
Mm-hmm.
So that allowed us to do a pragmatic approach with a choice of intervention. And another aspect of pragmatic trials would be no follow-up. You don't have assigned follow-up. It's during routine care.
Mm-hmm.
The point is you're trying to mimic real world.
Yeah, because in a tightly controlled trial, as you say, if you have planned check-ins, that can create a halo effect where patients might just be way better at putting on their emollient because they're being watched, they're being observed. And so rather than being part of routine care, so that's how it applies here.
Yeah, no, that's an excellent point. And so if we did a tightly controlled study, we found a positive effect, and then all of a sudden we tried to then implement that approach into the real world, it doesn't work. And then we wonder why. And it's because the study is done differently than it's implemented in the clinic. In this pragmatic approach, you try to make the study design mimic real world. So that's what we did. It does bother some people because we don't have assigned visits. We don't monitor adherence, right? Because we don't, unless you do that in clinical practice, which you don't, right?
Mm-hmm.
And so that's bothersome as a scientist, but the outcome, if the outcome's positive, you know that it's going to work in clinical practice.
Mm-hmm. Or has a higher likelihood to potentially work in clinical practice.
Right.
Let's get a little bit more into like the actual structured parts of the clinical trial. So you randomize people 1-to-1 to what? To the choice of 5 emollients versus just routine skin education. And they were basically randomized at what point?
So we had 25 different clinics across 4 states. And so when the participants, when families, you would call them dyads, like a parent and a child or a guardian and child, when they would come in for usually their first well visit check or their monthly well visit check, we had to catch them before 9 weeks of age. Then the guardians were offered the study and were randomized right there in the clinic using iPad consent. And that's how they're enrolled. They do their baseline questionnaire, total of 9 minutes to get through consent and baseline questionnaire. We had central study team available to answer questions. And then they were mailed an emollient. That's the best we could do. We couldn't provide emollient there in the clinic, but we would mail them their choice. And so everything was done from a central site. And that's why it's called a decentralized trial, because it was just one hub. And then we would mail out questionnaires, email questionnaires, and mail out emollients over time to the participants in their home.
And then what was your outcome of interest? What were you ultimately trying to measure and at what time point?
So we say cumulative incidence. So atopic dermatitis at any time in the first 2 years. And that was recorded by the clinician in the clinic in their medical record.
Okay, so the primary care physician had to make that diagnosis.
Correct. So ahead of time, they were trained in what the criteria are for atopic dermatitis. So they all went through training. But the awkward thing was that they had no idea who was in this study and who wasn't.
Okay, so they were blinded.
And so we would have to just encourage them for all your patients, which I know you do already, but just make sure that atopic dermatitis is documented if you do make that diagnosis in clinic.
And so what did you ultimately find?
Sure. So you mentioned the Cochrane review that was negative. And I was part of another study called the BEEP study, which was the other largest randomized controlled study in a high-risk group. And that was in the UK. And that was a completely negative study. And it was very disappointing. And so I was expecting this to be a negative study. And in fact, it would have been a lot easier to explain if it was, because then it would be consistent with the other largest study.
Mm-hmm.
But to my surprise, on data reveal day, we had a data coordinating center. Of course, I had never seen the data for the entire study. It was a positive study. In the overall population, using one of the 5 emollients reduced the prevalence of eczema or the odds of getting eczema by 2 years of age by 16%. And so it was somewhere, the percentages were quite high actually who developed eczema. So in the control group, it was like 43%. And in the moisturizer group, it was 36%. So those are quite high numbers, but there was a statistically significant reduction in atopic dermatitis at 2 years in the moisturizer group.
That is a high percentage of folks being diagnosed with atopic dermatitis. Why do you think that's the case?
It's hard to explain, although I'm very happy that we did a lot of different atopic dermatitis definitions, because that really makes a difference, how you define AD, right?
So what you're bringing up is in secondary analysis, you used different ways of defining atopic dermatitis through looking at the medical record to see if you can explain why this was happening. Is that a fair assessment?
Yes. And so I think it also, like good research, it always brings up further research questions, but our other definitions were a parent report of eczema from a provider. We had 2 validated questionnaires that had been validated in the past with other populations. And we restricted some analyses to only atopic dermatitis that needed a prescription, so-called more clinically relevant eczema.
Did you also find a difference when you use these different definitions?
Absolutely. So we saw the exact same pattern and protective effect of the emollients, no matter what definition we used. And so that gave us confidence that the effect is real. And, the only one that was negative was a UK Working Party criteria, which is a diagnostic criteria that was really designed for adults and hadn't been validated in kids, but still saw the same trend for that set of criteria as well.
So I'm sure this is going to be surprising to a lot of people in the atopic derm community that probably don't think emollients work. How do you think it should inform practice? Should we be recommending emollients for prevention of atopic dermatitis?
Well, there's one more wrinkle in the story in that the participants who came from a high-risk group didn't do as well as the participants who were not considered high risk.
And by high risk, you mean people that, say, had a family history of atopic dermatitis?
Exactly. So that's the classic definition of high risk, is not just a history of atopic dermatitis, but a history of atopic disease. So hay fever or allergic rhinitis, asthma, or food allergy in the family. That would be considered high risk. And so the emollient protection actually reduced the odds of getting atopic dermatitis by 2 years of age by 25% in that group, in the low risk group.
But not in the high risk group.
It's still protected, but not near as much.
This is fascinating. Where do we go from here? Do we need a larger study?
Well, what I'm proud to, state is that I feel like I don't need more studies. We designed the study to come up with the answer. So I'm never going to design, my goal is to never design a study where my answer is going to be, I need more studies or I need a bigger study. I wanted this to be the definitive study. And I think the answer is definitive for this population. Because of this decentralized approach and because of the use of rural community docs, it's an extremely generalizable study. The ethnic breakdown is very similar to the US population.
Mm-hmm.
And so I think it's a big study that's representative of different parts of the country, of different rural and urban and ethnic groups and racial groups and sex and gender. And so I'm very pleased with how this turned out. And so I'm taking the results at face value. And so, your question is, how does this translate? And trying to explain why this works in a low-risk group more than a high-risk group is very hard to explain. And the way I explain it is when you have a strong allergy family, like you have allergies and asthma and all that in the family, I think there's very little you can do from the skin barrier perspective to halt that. It's the immune system that's the problem. But if you don't have that so-called atopic gene set, then I think you probably develop atopic dermatitis because of a barrier problem, how you take care of the skin, exposures, too much bathing, whatever. And so I think they're going to benefit more from a barrier approach than families who have a really strong allergy gene.
So I take your point about this being an important trial, but I'm sure there'll be some people that will have some issues with the design, with the patient selection, blinding, do patients know, et cetera, notwithstanding. But I think you did delineate what some of the new studies need to be coming out. Is why? What's the mechanism? Can we design some kind of study, maybe some translational work, trying to understand the mechanism behind what your finding is? And perhaps a confirmatory trial, in science, doing things multiple times and showing it works in 2 trials, like for approval for certain drugs, as an example. So I think that this is an important trial and will have a lot of people talking.
Yeah, no, thank you for that. And I completely agree. And I think what's needed next, so it's hard, right? Like if you identify a family, how do you implement this on a population basis? Like, oh, you don't have a risk for eczema, but I want you to put this moisturizer on every single day.
Mm-hmm.
And then cost effectiveness will be important. So that's going to be some future analyses of like, is this a cost effective approach on a population level? And then like implementation science, if it is cost effective and it is worth it, how do we implement that? So yeah, still remaining questions, but at least you have something to talk about with families who are interested in a barrier approach. And most families, to be honest, are already using moisturizers. And there's data to show that for their children. And so this way you can give them a more directed approach to their skincare for their children.
Well, I want to thank you so much, Eric, for being on the podcast. I'm Dr. Adamson, and I've been speaking with Dr. Eric Simpson about the Cascade trial and the use of emollients in order to prevent atopic dermatitis. You can find a link to the paper and an accompanying editorial in this episode's description. This episode was produced by Daniel Massisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening. Catch you on the next episode of the JAMA Dermatology Podcast.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.